Welcome everyone to our breakout session, Health Assessments in Non-College Communities. Throughout the presentation, you can post any questions that you have for our speaker in the Q&A tab. And now it's my pleasure to introduce our speaker, Dr. Shelnutt. Dr. Shelnutt is an associate professor and extension nutrition specialist. Her research focuses on improving the environment to support making the healthy choice the easy choice. This work includes developing and adapting tools that measure perceptions of healthfulness of the environment, as well as tools that objectively measure the healthfulness of the environment. She is currently a member of a multi-state research team that has been developing tools to measure the healthfulness of college campuses and is leading the subcommittee to adapt these tools for low-income neighborhoods. Her work is reported under the approved multi-state NCII 9.3, using behavioral and environmental tools to identify weight-related factors associated with health in communities of young adults. In addition, Dr. Shelnutt is currently a co-PI of a 5-year USDA NIFA AFRI titled Advancing and Expanding HomeStyles, Shaping Home Environments and Lifestyles to Prevent Childhood Obesity, which will develop a curriculum to teach parents of 6 to 11-year-olds to make positive changes to their home environments and weight-related behaviors such as diet, physical activity, and sleep to reduce the risk of childhood obesity. Please join me in welcoming Dr. Shelnutt.
Thanks, Natalie, and I'm glad to see Gail Caldwell in the room. Hi, Gail. Thanks for joining us. I apologize. You have to look at my messy office in the back, but I can't get the background to work, so I'm going to share my screen. All right, well, good afternoon, everyone, and thanks so much for joining me today. This session is titled Health Assessments in Non-College Communities. I'm an extension nutrition specialist and at a large land-grant university, and so my extension work focuses on communities across the state, especially in my role as the PI of the UFIFAS Extension, SNAP Ed, and FNET programs. And the example I wanted to share today regarding health assessments in non-college communities is the Slice and Spice Meal Kit program that we have been testing for about 3 years. And I do think health assessments can be a really important part of community work so that you, either in extension or if you're doing research on the communities, can look at the impact that your program is having in different populations. So here's the outline for my presentation today. I'm going to talk about some background as to why we developed this program, really focusing on those health assessments that we did include and why. We'll talk about how we developed the Slice and Spice program, describe it to you, look at our study design, discuss some results, and then talk about some conclusions. So my passion is feeding people. Like I just want everyone to have enough healthy food for a healthy life. So really the main reason we developed this program was to address food insecurity across the state. And so food insecurity is the limited or uncertain access to adequate food to meet the needs of members in a household because of insufficient money or other resources for food. And the USDA releases its food security data every year, and the most updated data from 2021 was released earlier by the USDA this year. And according to these data, 10.2% of US households experienced food insecurity in 2021. And if we look at households with children, it goes up a little bit higher at 12.5% of those households experiencing food insecurity. Now, food insecurity is a major issue for a variety of reasons, but specifically it's associated with poor dietary intake, physical and mental health problems, higher rates of chronic disease, and increased healthcare costs. The other problem is that food insecurity is associated and more prevalent in specific sociodemographic groups. So households with children and single parent households and Black and Hispanic heads of households. This map also comes from the USDA and shows the average prevalence of food insecurity from 2019 to 2021. So if you look at the red states, they have food insecurity rates above the US average. The orange states, like here in Florida, our food insecurity rate is right near the US average. And then the yellow states have food insecurity rates below the US average. Now, while food insecurity is a measure of the ability to obtain food, the main cause of food insecurity is low income. In fact, according to one study, 34.9% of households with annual incomes below the poverty line experienced food insecurity, compared to only 5.1% with those who had incomes greater than 185% of the federal poverty rate. The current U.S. poverty rate is 11.6%, which translates to about 37.9 million people currently living in poverty. Although researchers argue that the way that poverty is currently measured underestimates that number, so there are likely more people living in poverty. And like food insecurity, poverty disproportionately affects certain sociodemographic groups, such as African Americans, Hispanics of any race, single-family households with children, and either a male or female head of household. So since the focus of today's session is about health assessments and health parameters, I wanted to spend a little time talking about the health parameters that we included in the study and why. And so this is a pilot project that we're going to talk about. And we included physical measures, social measures, and emotional measures of health, because food security status and socioeconomic status, or SES, are associated with negative health consequences in all of these areas. So we'll start with the physical measures of health. We did look at weight and BMI in this pilot, as you'll see. And there is a big study that looked at obesity and SES, and they found an inverse relationship, a strong one, between BMI and SES, specifically in women. So the data in men and children are mixed, but you do see a lot of research showing an inverse relationship in women. There aren't a lot of studies looking at body composition and income or SES, but there's one study that looked at the relationship between body fat and wages and found an inverse relationship. So people who had higher body fat percentage were actually making less in the US. There is a lot of research supporting a strong correlation between cardiovascular disease and socioeconomic status. And in fact, the American Heart Association has a scientific statement that says education, income, and occupation are strongly correlated with cardiovascular health. And hypertension and high cholesterol are both risk factors for different cardiovascular diseases, and both hypertension and high cholesterol have an inverse association with SES as well. So if you have low income or low socioeconomic status, you have a higher risk for developing hypertension and getting high cholesterol. And you see the same thing with type 2 diabetes. So low SES is a risk factor for type 2 diabetes, and people who live in poverty or have lower SES have worse glycemic control and have more complications as well. As far as social health measures, I don't know if you're familiar with subjective social status, but this is something that we included in this project. And subjective social status, or SSS, is the perception of a person's place in the socioeconomic structure in relation to others. And studies have shown that subjective social status is strongly associated with different health outcomes independent of socioeconomic status, and that lower social position is associated with poorer health and higher mortality. And some of the reasons that the research states that SSS might be related to different poor health include that SSS reflects personal and sociocultural circumstances more than SES. It influences hunger regulation and appetite physiologically. It impacts individuals' lifestyles, which then impacts. It can lead people to make social comparisons and feel a sense of relative deprivation, which also can lead to poorer health. And there's studies that also show that lower SSS can lead to negative emotions and chronic stress just because of their perception of their standing in society. And that can lead to psychoneurobiological disturbances, all associated with negative health outcomes. We included some emotional health measures, including perceived stress. So stress is our body's response to pressure, and perceived stress are the feelings that someone has about whether their life is considered stressful, based around events that are unpredictable, uncontrollable, or overloading. So these events may influence stress positively or negatively, depending on a person's coping mechanism. And signs of stress can be psychological, such as depression, or physical, such as GI disturbances. Research has shown that perceived stress is positively associated with food insecurity. The other emotional health measure that we included is body image. And body image is a subjective concept of one's physical appearance based on self-observation and the reaction of others. And negative body image or body dissatisfaction is concerning because it can contribute to the development of eating disorders, and eating disorders are associated with poor mental health. Now, there is minimal research that exists exploring the relationship between body image and food security status. There is a study that was done with adolescents, and they found, and these children were in 4th through 8th grade, they looked at the relationship between child food insecurity and body dissatisfaction. And they found that food insecurity was significantly associated with body dissatisfaction for participants with normal weight, overweight, and obesity, and among all racial ethnic groups. So there is something there. But future research should investigate the relationship between adult food security status and body dissatisfaction. Now, we discussed food insecurity a little bit earlier, and many food assistance economic relief programs do exist, including these that are listed on the slide. And while these programs do help to address food insecurity and economic stability, they have not completely solved the problem because food insecurity still exists, which leads researchers like us needing to develop alternative solutions to improve food access and food security. So one possible solution is meal kits. Now, meal kits are boxes of ingredients for at least one meal, along with step-by-step instructions on how to cook the meal at home. And meal kits have been growing in popularity over the past several years, but the market for meal kits is small compared to your traditional grocery shopping and restaurant sales. The cost for meal kits range in price from about $5 to $11 per serving for popular meal kits currently on the market. And they're primarily utilized by higher income demographics. There's not a lot of research published out there on meal kits, but the few studies that have been published focus on adolescent meal times. Very few studies have looked at feasibility and health impacts in a variety of different groups. Here's a list of some of the studies that have been published, and you'll notice that it's families, adolescents, children. New Zealand has done a lot of research there, as well as some here in the US. And if you look at the frequency and duration, it goes anywhere from 1 per week for 8 weeks to 1 per month for 25 months. But there has been a positive impact from these meal kits on specifically dietary quality, as well as family relationships. So you do see an increase in fruit and vegetable consumption as a result of participating in a meal kit project, as well as family meals being more positive. So for the purposes of this presentation, I pulled in the specific health parameters. So the study purpose was to investigate the impact of a healthy meal kit intervention on participants' physical, social, and emotional health parameters among African American main food preparers with children and low income. So we did a whole bunch of other research in terms of getting to the actual intervention, including focus groups with different groups, and the final population was African American main preparers of food with children. And we also collected a bunch of other data, but this presentation is focusing on the health parameters. So as the PI for SNAP-Ed, we have programming across the state of Florida, and we would hold cooking classes for adults in the community where they could spend a couple of hours learning how to prepare food. We would send them home with food so they could practice at home, as well as address their food security status. But our families have a lot of barriers for being able to attend one of those classes, right? There's transportation. Can they actually get to the class? And that's probably 3 hours of their day to get there, be in the class, and come home. Do they have childcare for their children? So it's a lot to ask for these families. So, we saw this struggle, and we were just trying to think of a way to make it easier for them to get more food as well as learn some nutrition. And so we thought about meal kits. And so, meal kits are expensive, as we talked about before. And so we thought of ways that we could help decrease the cost. And so what we did was we partnered with a local high school here in Alachua County that has a culinary arts program. When we did the focus groups before the meal kit development, we asked the families if they would be willing to go pick up the kit if it was in the area where they lived, and they said absolutely. So we were able to save money by not having delivery, and by having the students as part of their class actually prepare the kits for us. So the chef at the school ordered the food for us. We worked with the students to make sure that the meal kits were prepared correctly, and then the families would come to the school to actually pick up their kits and take them home. We did not provide direct nutrition education throughout the program, but we had several dietitians involved in this project, and we developed indirect nutrition education handouts that were included in each meal kit each week. We did include a participatory approach. So in terms of the marketing and even the logo, we included input from our target population and the students involved in the project. The recipes were adopted from existing USDA What's Cooking recipes or created by the culinary students at Eastside High School. And we looked at the recipes, shared them with families, had them rank them, and really chose the recipes that were most highly ranked and appropriate for our target population. So participants received meal kits with fresh, healthy, perishable, and non-perishable ingredients. And the ingredients were pretty much already prepared for them. So if there was a vegetable that needed to be chopped, it might already come chopped. If they needed a specific spice, maybe they needed a teaspoon, it was measured out for them already. And families received 3 meals each week for a total of 6 weeks at no cost. Each meal kit included ingredients to prepare 3 meals to feed 4 people. They got recipe cards with step-by-step instructions for each meal, a nutrition handout, and a cooking tool every week. So this is what the recipe cards looked like that were in the boxes. So we did nutrition analysis. We had really clear instructions. The ingredients were listed. And then this is what some of the indirect nutrition education looked like. Again, we had several dietitians involved in developing this program. Again, our model was unique in that we partnered with a local high school that's located in an area of town that is a lower SES area of town. So the families were right there and close to the school and able to come to the school and pick up those kits. The chef procured the ingredients. The students were the ones that actually prepared the meal, so they were able to learn the objectives of their culinary arts course by also learning about their community, the needs of their community, and how to help their community. So it was really great to partner with them in this project. We even let the students create a few of the recipes for the meal kit. We had to adjust the nutrition quality of some of them to make sure they met our standards as dietitians, but they really enjoyed being involved in that part. And the participants picked up the meal kits once a week from Eastside High School, which was, again, located in the center of the community we are targeting. And here's a picture of some of the students putting the kits together in the kitchen at Eastside High School. Logistically, it was a lot of work. So making this a research program, I had an army of undergraduate students helping because we had to be available every week to give the kits to the families because we were collecting data each week at the pickup. So they had a 3-hour window to come to the school to pick up the kits, and there were several different locations where they could pick up the kit if they were not able to come to the school. We tried to accommodate their needs because things come up. Okay, so in terms of recruitment, we recruited participants who identified as African American. Again, we did focus groups with African Americans before the study and decided to focus on African American main preparers of food who had a child in the home less than age 18. They had to meet low income criteria, so eligible for SNAP benefits. No food allergies. We did not want to deal with any of that, so we had them sign a form that there were no food allergies in the home, and they had to be able to come to the school to pick up the meal kits each week. Participant recruitment was interesting because at the beginning when we started, we wanted to do an intervention group and a control group, but we were having trouble with recruitment because they didn't really know us. They were kind of like, what is this all about? They didn't understand the project, but we were able to recruit at the school district, at a different church, children's medical services, And then once we got through the first group of people and they loved it and they loved the recipes and they were telling all their friends, by the time we were recruiting for the second group, we actually had to turn people away because we had so many people who wanted to participate, and even people in the first group who wanted to do it again because they liked it so much. So, you know, that's the importance of making sure you know your community and have buy-in from community members. Okay, so the intervention was a short intervention. It only lasted for 6 weeks, and participants received a meal kit with 3 recipes, as I mentioned, that each fed 4 people each week. Participants would come to Eastside High School or a nearby church to pick up the meal kits. Then the following week, the participants would fill out a brief process survey that asked if participants prepared the meal, if they liked the meal, and then willingness to pay for the meal, which is a completely different analysis that we did. Participants attended 3 data collection events that we called data collection dinners. The surveys and assessments listed here in the key were collected at some or all of the time points. And we had 2 different groups go through this project, and we had about 20 participants in each group. We did not have a control group though, because we were unable to recruit enough at the beginning. In terms of data collection, I had a lot of students who were involved at these data collection dinners. We had families come in for dinner. They stayed about an hour to an hour and a half to fill out surveys, literal paper surveys with a pen, sitting with a trained research assistant who could be there to assist when possible. Physical health parameters were obtained by trained research staff using standard procedures and recorded on data collection form. And all of the data, the paper-based data, were then taken back here to UF, where I had students who entered the data into an online portal, and it was all stored in REDCap. So we uploaded the data. We had students checking and rechecking the uploaded data to make sure that everything was entered correctly. Okay, now in terms of the outcome measures that we looked at, specifically related to health parameters, the physical health parameters that were assessed at baseline, post-intervention, and long-term follow-up included height, measured with a stadiometer, weight, measured with a digital scale, body fat percentage, measured with a handheld BIA, blood pressure with an Omron brand electric machine, and non-fasting blood glucose and blood lipids, measured with a Cholestic LDX analyzer. Measurements were obtained by trained research staff using standard procedures. So those were the physical measures of health. The social measure of health, remember we talked about subjective social status, we used the MacArthur Scale of Subjective Social Status to assess SSS, or subjective social status. This tool shows an illustration of a ladder, and the prompt for the ladder says, imagine that this ladder represents the place that people occupy in society. At the top of the ladder are the people who are the best off, those who have the most money, most education, and best jobs. At the bottom are the people who are the worst off, those who have the least money, least education, worst jobs, or no jobs. Please place an X on the rung that best represents where you think you stand on the ladder. And this question was asked twice because the question was asked about their standing in their society as well as their standing in their community. So a score of 1 indicates the lowest rung on the ladder, and a score of 10 indicates the highest rung on the ladder. And we assessed subjective social status at all 3 time points. We looked at body image as well, and we used Stunkert's figure rating scale to assess body image dissatisfaction. So this tool represents 9 different silhouettes ranging in apparent weight, with 1 corresponding to the smallest frame and 9 corresponding to the largest frame. Participants were asked first to identify which silhouette best describes themselves, so their perceived body image, then to identify the silhouette that they want to be, described as their desired body image, and then body image dissatisfaction was calculated by subtracting the number of the silhouette that the participant identified as their current size from the number of the silhouette that the participant desired to be. Therefore, a score greater than 1 indicated a desire to be thinner, a score of 0 indicated body image satisfaction, and a score of less than 1 indicated a desire to be heavier. And participants completed this form at all 3 time points as well. And then for perceived stress, we use Cohen's perceived stress scale, which is a 10-item scale, including 10 multiple choice questions with the following 5-point Likert scale response options of never, almost never, sometimes, fairly often, and very often. Questions are framed within the last month and ask about participant feelings and thoughts to different situations. Each response is assigned a point value, and a composite score is calculated by adding the points for each question. So the points can range from 0 to 40, with a higher score indicating higher perceived stress. And the Cohen scale was used at all 3 time points. And lastly, the research team developed 3 questions related to stress for shopping, cooking, and family meals. So the questions were, what effect, if any, did the meal kits have on stress related to shopping for food, cooking, meals, and eating together as a family? In terms of data analysis, for the 3 stress questions that were developed by the research team, we used descriptive statistics to analyze those questions. But for all of the health parameters, we used linear mixed models since there were 3 time points we were looking at. And then if there was a significant change across the time points, then we used pairwise comparisons of estimated marginal means to look at which time points were significantly different from each other. So the results, I was not expecting any change in any of the physical health parameters, to be honest with you, because it was just 6 weeks and we were only providing 3 meals out of their whole week. But we did want to be able to collect these data to characterize the population and look at these measures with some of the other measures that we had also obtained. So looking at weight, there were no significant changes in weight seen over time, but the results were trending towards significance. And if you'll notice, the different standard deviations are pretty large. So there was a lot of variation in weight, but it still stayed pretty consistent across the study. And there was no change across time for BMI or body fat percent. There was no change seen in blood pressure over time either. There was no change over time for any of the blood lipid measures, but we did see with blood glucose that there was a significant change over time. And when we did the pairwise comparisons, we saw a significant difference between baseline blood glucose as well as long-term follow-up, as well as post-intervention versus long-term follow-up. But keep in mind, this was non-fasting blood glucose. Now, for subjective social status, we did not see a significant change across time points for community subjective social status, but we did see a significant change across time for society subjective social status. And when we did the pairwise comparisons, it showed that society subjective social status increased significantly from baseline to post-intervention, but there was no change from post-intervention to long-term follow-up. So there was a change in SSS. And as far as perceived stress, there was a significant change over time for perceived stress, and pairwise comparisons show that there was a significant difference between baseline perceived stress and post-intervention perceived stress. And for body image, there was no significant difference across time for any of the body image outcomes. Now for the 3 questions on stress related to food shopping, cooking, and eating together, there was a positive impact on stress for shopping for food and cooking. So a majority of the participants said that their stress decreased related to shopping for food and cooking. And half of the participants stated that their stress related to eating together as a family also decreased. Although if you look at the top, there was one person that said that their stress level increased after having meals with a family. So we didn't get to tease that out. I'm not sure what happened at those family meals. So in terms of physical health parameters, as I said before, I really wasn't expecting any change or much change at all with the physical health parameters because it wasn't a very intense intervention and it only lasted for 6 weeks. So I was surprised to see that change in blood glucose in long-term follow-up. Again, it's non-fasting blood glucose, so we have to interpret that with caution, but perhaps in future studies, we should consider using hemoglobin A1C instead of non-fasting blood glucose. And maybe if we want to try and see more significant changes in physical health parameters with a study like this, we consider a more intense intervention where we're providing more meals during the week. The other thing is we didn't follow any specific dietary pattern per se. So maybe if we focused on a Mediterranean diet or a DASH diet, we would see more significant changes. The other thing is the nutrition ed, remember, was just indirect education. We didn't have anybody teaching them about nutrition. We gave them those handouts and had them, kind of read it at home. So perhaps in the future, we could connect a program like this with direct nutrition education, such as SNAP education. So could we recruit for a nutrition ed series and then send families home with boxes as an incentive? Perhaps we'd see some changes in physical health parameters if we did something like that. And then social and emotional measures, like this was what really got me excited. So I was excited to see a change in subjective social status for society, as well as a change in perceived stress. So, I got the opportunity to talk to a lot of the families that were involved in this project. And before this study, a lot of them had not ever even heard of a meal kit before, right? And as I mentioned, the current meal kits that are really popular are really expensive, and they really cater toward a higher income demographic. And so we made sure that our meal kits were just as nice. The food was fantastic. The recipes were really good. And so, perhaps having access to something like this was able to increase their perceived social standing, right? So we still have to tease some of that out, and we're in the process of doing that. And the other thing that made me really happy was the improvement in perceived stress. Our families have a lot going on right now. They have a lot of stress happening, especially lately with the increase in inflation and prices and everything. And so the ability to take some of the stress off of their plates, no pun intended, was important to me. And we were able to see that in that survey. And the other thing, in my conversations with families, one of the things that they really learned during the 6 weeks was about meal planning, right? It seems so obvious that meal planning is so important, but they loved knowing that they were going home, they had the recipe and ingredients for a meal. They didn't even have to think about it. They didn't have to go to the store. And so, the fact that they were able to take that away, and a lot of them continue to do so even after 6 months, was really important and does contribute to decreasing the stress. Now, the American Psychological Association has this report out called Stress and Health Disparities. And stress, according to the World Health Organization, is considered one of the top 10 social determinants of health. And this report reviews and discusses stress as a driver of health disparities. Now, this is important because there are disparities in the frequency, intensity, and duration of stress exposure. And if you consider our families with low income, they experience stressors that others don't, that can lead to threats to their health, safety, and economic advancement. So they're dealing with more stress and different stress than somebody maybe who has more resources than SNAP-eligible families. The report also provided some recommendations for interventions to reduce stress and manage stress. And we really felt that our intervention, at least the pilot, addressed some of those, including improving access to health promotion resources. So the indirect education, the recipes and all of that stuff, we provided that for them. Interventions to improve economic opportunity and access. So we provided free food for 6 weeks, and we also provided incentives for their time to take the surveys. And that was really important to them. Finally, down by family interventions, an intervention to promote positive parent-child attachments. The families would talk to me about how their kids would love to come in the kitchen and pick up the recipe card and then be like, okay, I want to do this part and you can mix this. And so they really enjoyed being in the kitchen together and then spending time eating the food that they had just prepared. So in conclusion, meal kit intervention is a creative alternative approach to increasing access to healthy food. In terms of health parameters, meal kits may improve subjective social status and perceived stress, as well as stress related to food shopping, cooking, and eating together. And then, in summary, health assessments, as we saw here, can be important indicators of impact of different community interventions. So again, I'm an extension specialist, and encourage our agents across the state to include some kind of health assessment so they can see how their education is making an impact. Now, some strengths to the study. We did include focus groups to help develop the meal kit intervention. I really think that partnering with the culinary arts program was an innovative approach to developing the meal kits and making it available to families. And we had those objective measures of physical health. Some limitations, we had a small sample size, so it is a pilot study. It was a short intervention. We didn't have a control group, as I mentioned before. We only collected data from the main preparer of food, and then there was some self-report observations from the children that the main preparer also gave us. Future directions, we were able to use the data from our pilot study to successfully get funding from Walmart to expand this project to 3 other counties. And so we have spent the last 2 years, we learned a lot from the pilot in terms of logistics. We made those changes and implemented it in, we were out in Putnam County as well as Orange County and a couple other schools here in Alachua County. So we have completed all of our data collection and are currently in the process of cleaning the data and analyzing the data so we can start presenting our results and getting those publications out. Now, one of the neat things that we did in the Walmart study is we included a veggie meter. And so I don't know if you've ever seen a veggie meter before or have ever heard of the veggie meter, but it is an objective measure of fruit and vegetable intake. So, you know, one of the problems with dietary intake and studies that look at dietary intake is that it's all self-report, right? So with the veggie meter, you put your finger in that little tool that looks like a pencil sharpener, and it can actually, it's a light, so it doesn't hurt. It's a light and it's able to measure the carotenoids in your skin and compare you on a scale to the rest of the US. And then we can estimate about how many servings you get a day, and you can change your Vegemeter score within a few weeks of changing your diet. And our participants and college students that we've been doing it with love the Vegemeter. It really is a behavior motivator because they want to change their diet so they can increase their score and they compete against each other. So it's been a really great addition to the current Walmart study with the meal kits. So highly recommend if you're interested in looking at fruit and vegetable intake. So I just want to thank Kaylee and Lauren, who were my PhD students who worked on this. Here they are during one of our data collection dinners. They were key to this project. They did an amazing job. And then my colleagues, Anne, Lisa, all of the students in my lab, Eastside High School, took a lot of hands, a lot of bodies to make this work, and I'm really thankful for all of their dedication. So with that, I will take any questions you may have. Any questions? So Jamie, hi. What do you think surprised you most about this study and the results found? You know, it was the first time we did this, so I was surprised and excited about the change in perceived stress and subjective social status. Again, just the ability to pull some weight off of their shoulders, provide that food, give them a little, you know, easier night at home, made me happy. So I was surprised about that. I was also surprised about how, you know, logistically, how much work goes into doing this kind of study. All the primary data collection we did, keeping up with participants week to week. You guys are rock stars when it comes to, you know, the students being involved and making it a successful approach. Thanks for the question.
All right. Well, if there are no more questions, then I'd like to thank you very much, Dr. Shelnutt, for this very informative presentation, and remind you all that the next session, oral research program presentations, will start at 3:15 p.m. Eastern Time back in the main session room. So you're welcome to stay here and discuss any of the points in the presentation, or you can head back to the main room by clicking the black box on the right of your screen. Thank you very much.
Thank you.